I hope everybody wore their Sunday best because we're filming today. You all are going to be on YouTube. I'm not kidding. So we're having a little bit of internet connection issues, so I'm going to actually move things out of order so that we can cover our website while we still have internet connection. But I just want to make sure everybody knows who's here, and obviously all of the plans, when they come up, will introduce themselves. I'm Cindy McGrath. I'm the person that you hear from by email frequently. Paul Murphy is our Director of Operations. Donna Wortman is our Assistant Director of Operations, and I'm sure you all have spoken to both of them frequently. Judy Satana oversees our Public Information Unit, and Ashley Rasmussen oversees the WellMass program. So for all of you that have eligible employees in the WellMass program, please make sure to see Ashley today. So with our HMO and HMO type options, here the PCP is required, and usually referrals are required as well. With a HMO, there are no out-of-network benefits except for emergency care. We have the named plans here. Tough Spirit is an EPO, so the difference between an EPO and an HMO is the fact that the PCP is not required for referrals. And then we have our PPO options, Harvard Independence, Tufts Navigator, Unicare Community Choice, and Unicare Plus. With these, members will be encouraged but not required to designate a PCP. These plans do have out-of-network benefits. I would never encourage people to routinely seek care out-of-network because the out-of-pocket costs are quite high. They only have 80% coverage of reasonable and customary charges or under Unicare under allowed amounts, but they do have that benefit. And then we have the indemnity plan, which is our comprehensive plan that's available throughout the world. You can live anywhere and be in this plan. We always recommend that folks choose the with CIC option. If they choose the without CIC option, it would be similar to being in a PPO and going out-of-network care for all of your care, which is very costly. So the new state mandated benefits that are going into effect as of July 1st are outlined. And then under federal health care reform, a new communication is required, which is called a Summary of Benefits and Coverage, or SBC. So every plan is going to be mailing to its current members an SBC. And these SBCs for all 12 of our employee health plans are on our website at that website address. But what this means for you as an employer is you must give every new employee that website. So when I get to the form section, you'll notice that the employee acknowledgement form has changed, and the reason for that is it is required that employees be made aware of where they can get these SBCs. So the guide and the home mailing all included this website, so all folks have been notified in writing during annual enrollment about the new SBCs, but your job is going to be for your new hires making sure they're familiar with where these SBCs are. And then this is a nice enhancement. You know, obviously if people are well, they're not going to get sick, they're not going to use health care as much, so we have added for all of our plans there'll be a gym membership reimbursement of at least $100 per family, and then more rich tobacco cessation counseling benefits across all of our plans. The other major change is for July 1st, as if we weren't busy enough going out for health plan benefits, we also went out to bid for our mental health carve-out vendor for all of the Unicare plan members, as well as Tufts Navigator and Tufts Spirit. And We selected Beacon Health Strategies. Their website and phone went live yesterday, and this means no benefit changes, and Beacon will be up here in a minute to talk about the transition and what will this mean for members. The other good news is the EAP Coordinator. Hopefully all of you are using this free benefit. This is a great resource for you. Whether you have a critical incident debriefing, low morale, need some consultation, management consultation. This is a free service. Sue Cooper has been hired by Beacon, so as of July 1st, her contact information will be changing to that enumerated. So up until June 30th, if you need to get a hold of her, you'll get a hold of her at her current phone number and email address, and then as of July 1st, you can contact her at this new contact information. Other health plan benefit changes, Fallon Select will be tiering hospitals, Tier 1, Tier 2, Tier 3. Neighborhood Health Plan has put in place a program whereby if you're taking maintenance medications such as for high cholesterol or ongoing health issues where you have to take medication forever, you will need to get a 90-day prescription through your physician and have it refilled through either mail order or certain pharmacies. Then all of the Unicare plans are going to have the flat PCP copay as of July 1st, and then the specialist copays are standardized across all of the 3 plans. So I am going to have our health plan panel come up first. And you'll see at the back, what I've done is to try and keep it fair so that the same people aren't going last, which is the worst spot in the agenda. We're rotating these panels through, so you'll see I've noted where the panels are. What they'll be talking about is at the back of your packet, so you can refer to the final slides, and I'll let them introduce themselves and Joanne's. Yeah, I guess they picked you.
Hi, I'm Debbie Fraser from Unicare. I think most of you probably know me. There's a lot of familiar faces in the group. I think what we'll do first is everybody will introduce themselves, and then we'll go over what the GIC wants us to go over this year, and then we'll take questions at the end.
Hi, my name is Joanna Penta. I'm from CVS Caremark.
Good morning. I'm Ryan Wilson from Neighborhood Health Plan.
Hi, I'm Jennifer Curcio from Tufts Health Plan.
Julia LeBrun with Fallon Community Health Plan.
Good morning, Glenda DeBarge from Health New England.
Good morning, everybody. Elaine Wilson with Harvard Pilgrim Healthcare.
Well, hello again. The GIC wanted us, and it's at the back of your packet, I think, what they are having us go over this year. We'll discuss our networks and any changes we may have made to them, any hospital or tiering changes, what our plans are for gathering PCP information, prescription drug management programs and how they are handled throughout the different plans. Out-of-area coverage. Everybody always wants to know what their full-time students will be able to do. And then we're going to go over the rehab benefits, physical, speech, and occupational therapy. For Unicare, as you know, the basic plan doesn't have any network, so obviously it's the same as it was. You can go anywhere. There's no changes. For the Plus plan, Our hospitals and physicians, of course, are tiered every year, so there's always some movement in there, and that's why Cindy pointed out it's very important that you get our directories and that you look and see, and encourage your people to look and see and make sure that the physicians and the hospitals that they were using are still at the same tier in case it makes a difference to them and they want to make a change. In community choice, we've actually added 7 new hospitals. None have been dropped. So I know a lot of you have members out here that use community choice, and the hospitals are still in community choice out here. The only one out here that we've added is Fairview, which is, I think, a little west of here. The rest of them are sort of in the more in the eastern side of things, such as Mount Auburn and Lawrence General Hospital, et cetera. All right, as far as the networks go, the where you can live to belong to the different plans hasn't changed. If you're in the basic plan, you can live anywhere in the world. In fact, it is the only one that does allow you to live anywhere outside of New England. The Plus plan is for primarily New England. It doesn't apply to Vermont, and it still isn't open to Vermont, and to only certain areas in Connecticut. And so if you have people that are in the Connecticut area that are looking at Plus, I suggest that they look online and make sure that their area has physicians and hospitals that they want to use, because that's the important thing. And then community choice is available here in Massachusetts, with the exception of the islands. You can go to Cape Cod, but if you're so fortunate to live in Nantucket or Martha's Vineyard, unfortunately, you can't use community choice. As far as gathering PCP details, right now, Unicare doesn't require a primary care physician. We are not, at this point, having people call up to give it to us. We encourage people, then there'll be information going out to your employees and whatever, encouraging them to get PCPs, because everybody recognizes, I think the studies show that people that have primary care physicians tend to do better health-wise throughout their lives. And we've identified who the primary care providers are here in Massachusetts, and we do look on the back end through the data and see what's going on with our members. I'm going to leave prescription drug management to my friend here from CVS Caremark, and then out-of-area coverage. If you are traveling, or you have students that are out of state, you can belong to any of these plans as long as you are residing in the service area. And they have access to the Travel Access Network, which is a national network for Unicare. Of course, what you're trying to do is not that they can go anywhere, but we're trying to protect you against having balanced bills. And so if you use the Unicare Travel Access Network for your emergency and urgent care, which is mostly what's going to be used. If you are living outside of New England for more than 90 days, and I mean, you really go to Florida for 5 months out of the year, that type of thing, not that you're just traveling around a lot, but you really are going somewhere and staying there, you really have to be in the basic plan, because that's the one that covers you anywhere. Our physical therapy and occupational therapy benefits it's a $20 copay, but you do require to notify us ahead of time. It is reviewed for medical necessity. It is a rehab benefit in the sense that it's to get you back to where you were before you either had the injury or disease. It isn't going to teach you how to ski or play the piano. Nobody obviously is going to be doing that, but you're not going to be necessarily better, get better, and it's not meant to be long-term, it's meant to be short-term. And speech therapy is 100% benefit with a maximum of $2,000 a year. And so there again, that's for school-age children, Most of it will be going through the school and through the towns themselves, but if you need services up and beyond what the school is able to provide through the town, then we'll look at those services. And I think that's about it for Unicare. So I'm going to pass you on to Joanne, CVS.
Good morning, everyone. My name is Joanna Penta. I'm here from CVS Caremark. I'm going to be spending some time discussing the pharmacy program that's associated with Debbie's Unicare state indemnity plans. What you're going to find is all of these health plans have a very similar, or have the exact, actually, three-tier copay plan design. But the primary difference between these will be the drug lists and the varying drug management programs. You'll also find that Caremark is the pharmacy benefit management program for folks that join Fallon as well as Tufts. But again, there's different drug lists and different drug management programs. So I'll be discussing the pharmacy benefit management program that applies to members that elect the Unicare plan. I'm going to spend a couple minutes just concentrating on 4 key areas. I'm going to talk a little bit about the pharmacy network. Then I'll move into the actual drug management program, so you're familiar with those. Touch a little bit on specialty medications, and then end with some just miscellaneous other important pieces of information. Okay, number 1, pharmacy network. Our pharmacy network is a national network across the United States. It includes CVS Pharmacy, Walgreens, Rite Aids, a lot of independent pharmacies, as well as the pharmacy, I believe, that's here in the Amherst area. Members can use any pharmacy they'd like when they're getting an acute short-term medication. Probably the primary question you get from most of the members that are joining the plan is, do I only have to use CVS Pharmacy? Does everyone here know the answer to that question? The answer is no. You don't only have to use CVS Pharmacy. We own CVS, but you have the ability to use any pharmacy that's in our network for a short-term medication. Let's talk a little bit about maintenance drugs. Maintenance drugs are drugs you take every single day for the rest of your life. They're for a chronic condition. In those situations, a member really has 3 choices when they go to fill a maintenance drug. They'll be allowed 2 fills at any retail pharmacy of a new prescription. We don't basically want anyone to go without their prescription. So they'll be allowed 2 fills at any pharmacy, and then they have to make a choice. First choice is, do I want to use mail service, and very convenient, and have that prescription shipped to my home? That's the way I did it. 90-day supply shipped to your house. The other choice they have is to utilize a CVS Pharmacy. Because we own CVS Pharmacy, we extend the ability to pick up a 90-day prescription at a CVS Pharmacy for the exact same copays you would pay at mail service. The third option the member would have is, say they want to use Walgreens. They've been using Walgreens for 20 years. They want to continue using Walgreens. Under this plan, they would have the option to do that. They would be required to call customer service and opt out of the network, and then they would be able to utilize a Walgreens or a Rite Aid to fill that maintenance prescription. They'd have to go back every 30 days, and they'd be required to pay that 30-day copay every time they pick up the drug. So it's going to cost them a little bit of money, extra money, but the option is available to them. All right, let's talk a little bit about the drug management programs. I'm sure you've gotten lots of questions from your members regarding, step therapy, prior authorization, quantity limits, brands with an exact generic equivalent, as well as our plan has certain drug exclusions. As far as step therapy goes, there's about 21 or so therapeutic classes where there is a generic alternative within that class that can treat your condition. So in a situation, most situations, brand drugs are going to require that you try and fail the generic before you step up to the brand drug. Once your doctor says you've tried and failed it, and sends us in a form certifying that you have tried it, there would be a prior authorization to allow you to obtain that prescription. It's just a utilization method to ensure that your condition can be treated by the generic. Prior authorization is also on other drugs, and this is for clinical appropriateness, such as an anti-obesity drug. We want to make sure that your diagnosis matches that particular drug, as well as quantity limits would apply to drugs like migraine medications, and those are basically for safety situations to ensure that your doctor is not over-prescribing an FDA-approved quantity amount. You probably also get some questions on brands with exact generic equivalents. A good example would be Lipitor. Lipitor went generic last November. When a drug goes off patent, usually 18 years or so, generic manufacturers then can make that drug in a generic form. In a situation like Lipitor, you are required to use the generic version of Lipitor once it went generic last November. There's no exceptions to that. You would be required to pay a higher copay if you say, I need brand Lipitor, I can't take the generic. So it would be a difference in cost between the brand drug and the generic drug plus the copay. Again, these are exact generics. These are not drugs like Diovan that does not have a generic. These are only drugs that go generic where that dispense is written applies, and that's even if your doctor certifies, you still need to take the generic or pay the extra copay. We also have some exclusions, Nexium, Acifex, ton of generic alternatives on the formulary to treat those conditions, as well as over-the-counters. There's lots of over-the-counter equivalents, such as Claritin and Allegra, that are also not covered because there are so many over-the-counter drugs available to members. Thirdly, I'll talk a little bit about specialty medications. It only impacts a very small % of people, but they're very, very high-cost drugs. For people that have like MS, rheumatoid arthritis, some of those really rare chronic conditions, you're allowed 2 fills at any retail pharmacy. Then you're required to use the specialty mail facility, and it would be shipped directly to your home. There is the ability, if you live in an apartment, to actually pick up that drug at CVS. CVS will not dispense the drug. Our mail pharmacy will ship it to CVS in a blue box. It's not opened, and these are for folks that live in an apartment and don't want their specialty drug on their doorstep, although these specialty drugs are in boxes that are hot and cold and very much protected so that they're, will be available when to use them. Most of those specialty drugs require prior authorization. Again, these are extremely expensive drugs. We just want to make sure that that drug is appropriate for your condition. There's also a lot of preferred drugs in that category, so there's an authorization process where we work directly with your physician to ensure that that drug is appropriate and being prescribed appropriately. Lastly, miscellaneous. Anybody here new groups with new members? Any new groups? Okay, so most of you probably know. If you do hire somebody and you have a new member, we don't work with their prior carrier to have their prescriptions transferred over to CVS Caremark. It would be their responsibility to either work with their doctor to get a new prescription if they want to use mail service or a CVS pharmacy for a 90-day pickup, or we can take the ownership by calling customer service and help them with that and help them coordinate that with their doctor. Make sure you tell new members to show their new ID card. Everybody gets an ID card. Make sure you tell folks to show them. We get a lot of calls at the beginning where people saying, gee, my claim got denied, and it was because it went to Blue Cross in Massachusetts. They forgot to show their CVS Caremark card as a new member. They also need to redo their step therapy and prior authorization for new members. Again, we don't transfer that information over, so it would be their responsibility to work with their physicians as well as our customer service reps if they have any questions on any of the protocols under the GIC program. I think that's it.
Good morning. Again, I'm Ryan Wilson from Neighborhood Health Plan, and I have the pleasure of filling in for a colleague who had a scheduling conflict today. So I'm going to do my best here to be clear and concise, but at Neighborhood Health Plan, there were no major network changes this year. We did add Jordan Hospital, which opened up the Plymouth County area to bring our hospital total to 68. There are still no hospital tiering by Neighborhood Health Plan, so that will continue going forward. And we do gather, or rather we do not gather PCP information. So we will basically assign a PCP at time of enrollment and then send out a letter encouraging the member to call in to change it at their convenience. And we also do outreach members, new members, so the opportunity will be there during that call to also change the PCP. Prescription drug management programs. I'd like to discuss the Maintenance 90 program. I think this is specific to NHP. We are requiring maintenance medication that somebody is on ongoing to be filled in a 90-day supply, and that will be at the same copay amounts as a mail order, and it can be done through, and again this is effective July 1st, and it can be done through pharmacies such as CVS, Rite Aid, Walgreens, or through mail order. And we do have step therapy If a new member or an existing member without a record of first step medication, the doctor can call Catamaran, available 24/7, and they can discuss that member's circumstances with Catamaran directly. Out-of-area coverage is covered for an emergency services worldwide, and students are covered. And physical therapy, speech therapy, and occupational therapy benefits are covered at a $35 copay. No prior authorization is required, and PT/OT is covered up to 90 days. Thank you very much.
Hi, again, I'm Jennifer Curcio from Tufts Health Plan, and Tufts Health Plan is happy to be offering both our Navigator and Spirit plans again for the GIC employees. I also want to mention in the back, Christine Field has come with me here today. She works on the retiree products, Tufts Medicare Complement and Tufts Medicare Preferred. In terms of network changes, there are no changes to our network. The Navigator plan is our full network plan, and the Spirit is our limited network plan. So the thing to remember for Spirit is it's not every hospital and physician, and you do need to reside on Massachusetts mainland. Martha's Vineyard, and Nantucket are not covered on the Spirit plan. Navigator is the full complement, all of the hospitals in Massachusetts. We have Southern New Hampshire and Rhode Island, as well as a majority of the physicians. But in terms of actual changes, there really are none to the network this year. Hospital tiering, we do tier our hospitals on both plans. They are tiered according to adult med-surg, OB/GYN services, and pediatric. And the only change this year for the tiers is Lawrence Hospital was a tier 2 on adult med-surg, and that actually is changing to a tier 1. Their quality scores increased so much that they were able to be dropped down to a tier 1, which is the lower copayment. And they were already tier 1 for OB/GYN services and pediatric services. Neither of our plans require a primary care physician. However, most people do have a doctor that they use. If you have a sore throat and you need to go get it checked out, you have a doctor that you call and you go to. So we are making an effort this year to gather the primary care physician information. We do have the ability to store it in our system, and we're going to be doing some outreach. This is outreach number 1, so I'm checking this off my list. Additionally, we have a flyer that's going to be in the enrollment kits. We have information on the Tufts Health Plan microsite, tuftshealthplan.com/GIC. The letters that we send to our members, we're going to update that to include information that they can call into member services and let us know who they use for their primary care doctor. Additionally, when you call into member services, we're updating the message, so there's a little reminder that if they want to let the rep know who their doctor is, we're happy to take and store that information for them. Members can either call in or they can update the information on the website. So there's 2 ways for folks to do it. I personally don't like to call anybody, so I just do everything on the website if I can. I talk all day, so when I get home, I really don't want to have a conversation with anyone. In terms of prescription, we do use CVS Caremark, and the programs that were mentioned do apply. However, also as mentioned, our formulary may vary from the other plans' formulary. So the most important things for members to do is to check the website or call into member services regarding what tier their drug may be on, and if it is one of the drugs that are in a prior authorization program or a dispensing limitation program, and if they're changing from one plan to the other, that does not automatically carry over. So our member services staff is trained on how to assist members to get that authorization transferred over if it's medically necessary, and also the providers that we contract with are also very well aware of what form needs to be filled out to be sent in order to validate medical necessity to have a drug that needs prior authorization or step therapy. In terms of out of area, as mentioned, we're a regional plan, so Spirit, you do need to live in Massachusetts and not one of the islands. And for Navigator, I mentioned what the service area is. You do need to have a Massachusetts residency, and you need to reside in the area. You cannot be out of the area for more than 90 consecutive days. So what that means essentially is if you live 6 months out of the year in Florida, this really is not the plan for you. You do need to live in Massachusetts. But you do, however, have coverage while traveling. So if you are traveling worldwide and you have an urgent or emergency situation, you will have 100% coverage minus any applicable co-payments. Students are allowed to reside outside of the service area. Again, they too are covered for any urgent or emergency care. However, all of their routine care does need to be done while they're home on breaks in the service area. Last thing, occupational therapy and physical therapy, they are short-term rehabilitative benefits. They have coverage for 30 visits per calendar year at the $20 copayment. But again, you do need to, short-term rehabilitative means, you suffer an injury and this therapy is going to get you close to where you were before the injury happened. So it's not a long-term benefit. Speech therapy is an unlimited benefit, and that too is covered with a $20 copayment. Thank you.
Again, my name's Julia LeBrun. I'm with Fallon Community Health Plan, and we offer two plans. We offer the Select Care Plan and the Direct Care Plan. The Select Care Plan is our broadest network plan. There's really no major changes. It is a network that goes from the New York border all the way into Boston, up into southern New Hampshire, down, step onto the Cape in the Plymouth area. We then have the Direct Care Plan, which is our limited network plan. And the way that I think about it specifically for where we are today out here in the west, if you're west of the Brimfield area, really it is the Select Care Plan that is available to you. The Direct Care Plan is mainly available Brimfield eastward. Okay, so it's mainly Central Mass, North Shore, and the South Shore areas. Both plans are HMO plans that do require members to elect a PCP. The way that we update PCPs, once we receive the enrollment file from the GIC, right after July 1st, we will write out to our members who have enrolled if the PCP is not on file, if they have not called in, encouraging them to give us a call or go online to elect a primary care physician. At the same time, we do place welcome calls out to any new members, and the members will then, at that point in time, also be reminded that they need to elect and assign a primary care provider. Both plans offer worldwide urgent and emergency coverage. So no matter where you are, whether you're in the United States or outside of the United States, members have urgent and emergency care services. Students do receive a little bit of an extension of coverage. So when they are at school, they can get that urgent and emergency care. But there are extenuating circumstances where they may receive other care, such as if they were home on vacation and had, let's say, planned knee surgery, and they are now going back to school and it requires them to have PT. PT can be authorized where they are at school. It was the planned surgery, though, that needed to be done when they were here in the service area. So any primary routine care does need to be serviced here in the network service area. Both plans have the 3-tier prescription plan. Again, the formulary is different for each carrier, so you want to ensure that the members are going online and checking out what the formulary has, what tier their prescription falls into so that they know what copayment they will pay for that prescription. And then there are certain drugs that have both the step therapy and or prior authorization requirements. So we do encourage members. It is out on the website. They can look up the formulary right there for their information. We also have coverage for physical and occupational therapy. Both therapies are subject to the applicable copayment under Direct Care and or Select Care. And with that, they have a 90-day per illness or injury coverage, and that is per calendar year. And then we also have speech therapy that is subject to the copayment, but that is an unlimited benefit per calendar year. So that summarizes Fallon Community Health Plan.
Good morning. I'm Glenda DeBarge from Health New England. Health New England is one of the limited network options through the GIC for actives and retirees without Medicare. And our second plan is also called the Med Plus for retirees with Medicare. We are both HMOs, both plans are HMOs, and our network covers primarily Western Massachusetts, which is the Berkshire, Hampden, Hampshire, Franklin counties, and parts of Worcester. We include all in-plan hospitals that are Western Mass hospitals are in network with Health New England, and we do not tier the PCPs or the hospitals. For primary care information, we're coming up with an outreach program for those who do not list a primary care physician through the transfer to our enrollment system. We are coming up with first claim that comes in from members will be the first, the PCP will list them from their first visit. So again, the first claim from that first visit with an in-plan primary care physician, we will list for that member. Members that are switching plans, again, the reps here have mentioned that the formularies are quite different. We do have retail pharmacy and mail order, as well as Access 90, which is 90-day supply through retail, but you get the 3-day copays for the 90-day supply. We also do offer the step therapy and prior authorization, as well as generic dispensation with Health New England. The step therapy, however, for existing members, we do a 180 or 6-month look back to see if you have filled that first agent, first line medication. For new members, though, we will allow for you to fill that step therapy medication as long as you're consistent for 4 months and you're compliant and consistently filling that medication. Because we are HMOs, you are to travel outside the service area, you are covered for emergency care or urgent care visits anywhere you travel. If you do have that emergency care visit, you do want to let member services know that you've had that visit. Otherwise, it will be flagged as out of plan. So when you do let us know that you've had that visit, you will incur that $100 ER copay. Student dependents are also covered outside the service area, but we do allow for additional services such as follow-up from an ER visit or allergy injections. Those are required with a prior authorization, but we do allow that for the student dependents. And then also for physical therapy, speech therapy, and occupational therapy, it does not apply towards the deductible, but is a $25 office visit copay with Health New England. And again, I want to mention that if there are members that are switching and looking to come to Health New England or vice versa, you do want to make sure that their primary care or their providers are in network with Health New England, and their formulary also, to make sure that they are aware of what tier the medication falls under. And you can go on hne.com to get that information.
Thanks, Glenda. Good morning again. It's Elaine Wilson with Harvard Pilgrim, and we too are very happy to be offered with the GIC again for this year for renewing. And our two plans are the Independence Plan, which is our full network PPO, and our primary choice plan, which is the limited network HMO. And we always want to caution folks to check their provider if they're interested in the limited network. It is a wonderful plan. As you know, the benefits are the same in network as they are in the PPO, but the cost sharing, the premium costs are lower. And it's a great way for folks to save, but members really need to know they need to check their primary care doctor, their specialists, and their hospitals to make sure that all of the providers that they wish to see are part of the network. Once they've established that the doctors are in the plan, it's a terrific plan. The network is a limited network. It's a smaller subset of our PPO, but it is a robust network. So even though it's a smaller network, there are many providers for folks to see. They just need to check. And we like to be sure folks do that, because if you are seeing someone who's not in the network, it's not covered unless it's an emergency, and costs can add up. So folks just need to be careful about that. And that brings me to the first point for the discussion of network changes. When folks are looking at the network, we should be aware that we've got today some physicians on Cape Cod who will no longer be part of the plan for primary choice only. So without doctors on the Cape, we are limiting enrollment to exclude the Cape, because we don't want someone to enroll in the plan who then has to travel too far to see a doctor. So Cape Cod won't be part of the enrollment area for primary choice. It will be mainland Mass proper, no Cape Cod, and no Martha's Vineyard and Nantucket. That's for primary choice. The PPO network hasn't changed, and the enrollment area is as broad as it ever was, all of Massachusetts, Rhode Island, New Hampshire, Maine, parts of Vermont, New York, and Connecticut. So for folks in Western Mass, that's important to know. As far as the hospital tiering, when folks are looking at the network changes, they want to observe what tier their hospital falls in, because that will tell them what their copayment will be if they're admitted to the hospital and what the quality scores are for the hospital. And we did have one change this year, and it was with Bay State, Franklin, that has gone from a tier 3 in the PPO to tier 2, which is great news. And that also means that it had been excluded from primary choice, but now it's added to the primary choice network. So there's a little more choice, especially out here in Western Mass, for folks if they're looking at primary choice. When you enroll in the primary choice plan, you do need to select a primary care physician, and we collect that data after we receive the information from the Group Insurance Commission of who's enrolled, we reach out to any new members and ask them who they'd like as their primary care doctor, ask them to call us or go online to Harvard Pilgrim Connect to tell us their primary care doctor. And if the member doesn't come to us after we've asked them to do so, we will assign them a primary care doctor. They can change that physician at any time, though, so no one's locked in. You may change your doctor whenever you like. For the PPO, it's not a requirement to have a primary care doctor, but we do encourage members to do so because it's important to have someone to call when you are sick. So we encourage folks to have a primary care physician, and we're working to, over time, be able to collect that data from our members because, in fact, most people do have a doctor that they know to call if something goes wrong, and we just would like to know who that is and encourage folks who don't have a primary care doctor to think about getting one. For prescription drug coverage, we all share the same co-payments, as you know. With Harvard Pilgrim, there are no changes to our prescription program. It is an open formulary, so any medication that exists that's medically necessary is covered for people. It's just a matter of what tier the medication falls into. And the formulary doesn't change other than when a new prescription is approved by the FDA, and that might shift. If a new medication comes in to treat, say, cardiovascular disease, then other medications may change tier. So folks should always check their medication and see what tier it falls into. Other than that, that's an ongoing thing. There are no actual changes to the pharmacy program for this year. As far as being out of the area, both plans, the PPO and the HMO, cover enrollees if they're lucky enough to travel. They are covered worldwide. For the PPO, a member needs to reside within our enrollment area, which are the states that I mentioned, the New England states that Harvard Pilgrim is offered in. For the HMO, as I talked about, folks need to live in Massachusetts itself, and that excludes the Cape, Martha's Vineyard, and Nantucket. When someone's out of area and they travel, they are covered for any emergencies they might have. A PPO member actually has access to our national network. If they are in another state and they'd like to see a provider affiliated with Harvard Pilgrim, they may do so, and they'll be covered at the in-network level. And for HMO folks, that is restricted just to emergency or urgent care while they're away. And for students who live out of area, they are covered as well on either plan. And if it's the HMO, we would recommend that if the student needs ongoing care while they're away at school, they can have that. It just needs to be arranged for them by their primary care physician. And the residency requirement applies to everybody but full-time students, because we certainly don't want to restrict where someone's going and getting their education. So kids can live wherever they need to for school, but if they're on the HMO, their primary care doctor should arrange their care for them while they're away, unless it's an emergency. The physical, occupational, and speech therapy benefits are, for speech therapy, unlimited. For physical and occupational therapy, the benefit is up to 90 consecutive days per illness or injury. So if I'm on the PPO and I fall and break my leg, I'm covered for that physical therapy course of treatment for up to 90 consecutive days. And then after I've recuperated from that, I fall and break my arm, God forbid, I'm covered for that too for up to 90 consecutive days. So it's per illness or injury, and that's for both the HMO and the PPO. We also offer a third plan, Medicare Enhance, and in a nutshell, there's no network. A member can see anybody who's a doctor or provider that accepts Medicare. There are no network changes to talk about since that's anybody who accepts Medicare. The pharmacy benefit is the same on the Medicare Enhanced plan. Out of area, Medicare Enhanced enrollees may live anywhere in the United States, so that really opens up the world for someone who's retired and they want to move away. Unless they move out of the country, they can be covered with Harvard Pilgrim. And if they're lucky enough to travel, they may travel anywhere in the world and they'll be covered for the services that they need if they have an emergent or an urgent care situation again. Otherwise, no changes for Medicare Enhanced. And that's it for Harvard Pilgrim. We'll be glad to take your questions if you have any.
Any questions for the health plans? Yes.
Just the changing between plans mid-year and the impact of deductibles?
Okay, so the question is about the deductible and changing mid-year. We had desperately wanted to change the deductible to a fiscal year basis so that that wouldn't be an impediment for switching plans. The way it works right now is if you are in a health plan and you change plans but stay with the same carrier, the deductible carries over with you and you are not subject to new deductible. However, if you change carriers, you are subject to a new deductible because it is a calendar year benefit. We had wanted to change that to a fiscal year basis. The problem is the cost of changing it is $28 million. And given the fiscal constraints we're under, it wasn't a realistic option this year. We do hope to do it when things get better. Yes.
If you have two spouses that two separate agencies, they're both on a single plan.
Yeah.
But they're now having a baby, so they're going to get on a family plan.
Sure.
Both have the same carrier. Will the deductible move with the spouse?
So are they both with the same plan? Will you guys be able to identify that person, or would the person need to call you?
I think with Unicare, you'd probably have to call us. But we would certainly carry that deductible over into the family plan. But we might not be able to make the connection. Is that true?
So if any of you have that situation, have the employee call the plan. Yes.
Carryover deductible for the last 3 months of the year seems to look different with every plan, and it's causing some confusion because our members talk to each other. So one person gets credit for it, another person doesn't. We just had that happen with Health New England where somebody met their entire deductible the last 3 months of the year, didn't get credit.
Okay, so the question is, for folks that incur a deductible, they don't incur any deductibles until October, November, and December, we have this nice benefit where that will carry over into the next year. Glenda, you want to comment on this?
If a member has not met the deductible prior to October, November, and December, okay, but incurred in that quarter, it should have applied towards the following year. If you could give me the name or give me some guidance on that, I can definitely look at it, but that's the way it's supposed to be configured.
So the way it works is if the person hasn't incurred, any of their deductibles this year, but they incur, or we have a lot of groups that don't join until later in the year, then they would, if they incur the deductible October, November, December, it'll count towards their 2014 deductible.
Or any part of it. It's any, with Unicare anyway, it's any portion of the deductible. So you may have met $100 in August and then $150 in October. The $150 will carry over. If you meet all of it, the $250 in October, that will carry over. Or if you have 25 cents left by October 1st and you meet that 25 cents, then that 25 cents will carry over. It's really the part of the deductible that you incur during those last 3 months of the year.
Does everybody understand the way that works? Okay. Other questions? Yes?
Can I ask another one?
No.
Deductible on Health Preferred, that $3,400 deductible, it's in the brochure, they printed offline.
A deductible of, out of pocket?
Sure. The Tufts Medicare Preferred HMO renews every January, so it's sort of an off-cycle type of thing. It's $3,400. Sorry, I'm loud anyways, but the $3,400. It's not really a deductible. What it is you will never pay more than $3,400 out of pocket. So that means any co-pays that the person pays would actually be counted to that $3,400. So it's not that they have to pay $3,400 out of pocket for their first service. It's just the amount of co-pays that they will pay. Correct. It's a cap. It's a Medicare Advantage requirement that they asked us to put onto all of plans, and $3,400 was the least amount we could put on it. For the GIC plan, they have very little out-of-pocket for the Tufts Medicare Preferred HMO, $10 office visits, and no inpatient or outpatient hospital deductibles. So the likelihood of them ever reaching that is very unlikely, but it's not a deductible.
And so they wanted to make sure that you knew that's just for the Medicare plans.
The Affordability Care Act has been going into effect January 1st, 2014. Has the GIC looked at that in terms of how that might be impacted with...
So... Okay, so the question is about the Affordable Care Act. I will be talking in a minute about what's going to be happening to the connector, but the connector is going to become an exchange as of January 1, 2014. We are meeting frequently. In fact, I just got another email invite for another meeting next week because we're really not sure of all of the implications of that. That's my bottom line. We will be in touch with you. Other questions for the health plans? Yes?
Unicare is now offering the gym membership reimbursement?
So gym membership reimbursement is all plans, including Unicare.
And it's 100?
100.
It's $100 per family, and we're actually requesting that you try to submit it once a year rather than $5 every month or whatever, just for ease of. So there'll be a form that will be in your handbook, and it'll also be online. New for us.
Other questions?
Is that $100 fiscal year or calendar year?
Fiscal or calendar year?
Calendar year.
Yes. Okay, so the question is about the smoking cessation programs by plan.
With Unicare, it's going to be with, you can have medical professionals or certified tobacco cessation specialists that can conduct the program. You can go anywhere. It is going to be a member-submitted reimbursement. I don't see a lot of these programs being willing to submit to directly to the insurance plans, but if they do, we would certainly accept it. We are going to probably ask you to kind of keep track of your minutes because there are certain codes that give minutes, but it was basically, it's sort of going to be dependent upon you. There is, and this is, I would tell people, if they find a very fancy program, such as, maybe something out in Lenox that decides, the spa decides that they're going to have a wonderful program and it's going to cost them $5,000 and they can get their 300 minutes, they are probably not going to get reimbursed $5,000 for the thing, but any of the reasonable fees will be reimbursed to the member.
We don't have any programs, but we would cover the prescriptions.
She covers the prescriptions.
And I was not briefed on any changes, so basically the way it was last year will continue.
Tufts Health Plan is covering the smoking cessation. Currently, it's actually an unlimited benefit. There's not a minute cap on it, and it's with, again, providers, licensed providers, and medical professionals.
The same actually applies to Fallon Community Health Plan. We also offer a Quit to Win program that is available out in the community. we've been very well known for the smoking cessation program that Fallon Community Health Plan offers. We do have the ability, if there is enough participation, to provide an on-site Quit to Win program, but that would have to be addressed on an individual plan to ensure that there is at least a minimum participation number.
Health New England also offers the smoking cessation program. Believe it was up to 300 minutes in telephonic counseling as well with a certified and licensed provider.
And Harvard Pilgrim also covers smoking cessation. It is unlimited with either a primary care physician or a specialist or a smoking cessation specialist. And we also have a program for all members called Quit Works. It's available statewide, and the services are telephonic. So there's a couple of ways to get the benefit, and there's no member cost.
Any other health plan questions? Okay, thank you. So, OPEB, what does that mean? It's other post-employment benefits, and basically that's anything but pensions, but what do you think is the big cost? Healthcare. The state has a huge problem, $46 billion. Although the state has a big amount of that, the municipalities really have a huge amount of that. And so what happened was that a commission was established representing the Retiree Association, a lot of the unions, a couple of legislators, and then folks from the state side to meet to try and tackle what should be done to decrease this liability. They put together a set of recommendations that would change eligibility for retirement benefits for GIC health insurance and on the municipal side as well. And namely, it would sort of grandfather people, it would grandfather people that are already retired, it would grandfather people that are close to retirement, but it would change how many years of service you would need to work in order to be eligible for GIC retiree benefits. It was filed at the beginning of February as legislation by the governor. The legislature, it's in a committee right now. What the final outcome is, your guess is as good as mine. Obviously, if changes happen, we will be letting you know. But obviously, there's a lot of discussion about it. It's a huge problem. It's a huge nut to try and crack. I'm sure something will happen, but what the final legislation will look like, we do not know. The GIC last implemented new regulations quite a few years back, and it's been a busy few years since then, so we are in the process of changing our regulations. Obviously, federal law has changed in the last few years, namely that we are now covering dependents up to the age of 26. There's a new claims appeal process. And then on the state side, the fact that PCP can now include others besides physicians. So the regulations will reflect what our current practices are. Additionally, back in 2007, the first municipal law passed, then 2011, another municipal law passed, which meant we had two different regulations when, in fact, most of the information between the two is very similar. So what this will do is combine the two, and then where there are differences, primarily on the notification requirement, those will be specified. Our eligibility rules didn't cover anticipate things such as teachers that are covered during the summer, so that will be spelled out. And now municipalities have the option of retiree dental coverage, so that is going to be included. And then there's a 3-year lockout provision for municipalities who decide to leave the GIC and then later rejoin. And then the other substantive changes, we, as you know, cover dependents up to 26. We're going to cover orphans up to age 26 as well. On the BEAD waiver, this is when you have a new hire and they incur substantial medical costs. They have the option of buying back their coverage. It needs to be very clear that they can't have other health insurance, so that's spelled out. And then if a divorced spouse, if a couple divorces, they'll have the option of buying 2 separate coverages as long as they're GIC eligible, each individually GIC eligible. So the hearing took place last week. The commission will be voting on this April 12th. And then once they vote, we will get it on our website after that, and we will reach out to you so that you're familiar with all of the ways the regs are changing. Next, I'm going to have Lauren from Beacon Health Strategy come up and tell you a little bit about our new mental health vendor.
Hi, good morning. My name's Lauren Falls. I'm the Senior Clinical Director at Beacon Health Strategies, and it's really nice to be here today. And as a student here a number of years ago, many years ago, spent a lot of time in the campus center and find it's a lot smaller than I remember it, and really miss the pinball machines. But anyway, it's great to be here. So Beacon is the managed behavioral health organization that will be managing GIC benefits, and we were established in 1996 and have a very strong Massachusetts presence. Our first client was Neighborhood Health Plan of Massachusetts, and we've grown from 30,000 members to national now, about 8.2 million. In Massachusetts, we manage the benefits for NHP, Fallon, BMCHP, HealthNet Plan, Senior Whole Health, and now GIC, which brings us to almost 1 million members in Massachusetts, which is very exciting for us. Our current CEO is actually Tim Murphy, who you may know as the former Health and Human Service Secretary under Romney, who helped with mass health reform. He's sort of the architect behind Commonwealth Care. So he is our leader today. We have 8 states that we are in today. So when you think about national presence, we have about 3,000 providers in Massachusetts and around 6,000 nationally. We have a large presence in New York, Kentucky, Rhode Island, Hawaii, Texas, and a couple of other states coming up. So we're confident that our provider network will work for your members. I also think that the 3,000 and 6,000 don't fully represent the number of providers, because if you think about facilities, they're counted as a 1. It doesn't take into account all the doctors or other providers that may be working in the facility. So for Western Mass, we are fully in the network out here. All of the facilities, whether it's Wing or Berkshire or Bay State, are all in network with us, as well as a full continuum for outpatient, diversionary, detox services, et cetera. I want to reiterate what Cindy has said earlier, that with our coming on board, there is no change in benefits. So what people have today, they will have going forward. We do know that there are providers that are not currently in our network. There's a gap of about 20%. And so today we are actively outreaching to those providers to get them in network. Our current in-network providers, we've also sent contracts to say, we're with GIC now, please come on board. We're confident that people will. But if you have members who have concerns about their doctors not being in network, please call us, and we can either give you an update or say, gee, that wasn't on our radar. We will work towards getting that provider in network so that there will be little to no disruption for any of our members currently in service. To that point also, we are taking calls from members today, actually yesterday, and our website is open. So, and during the health fairs, people can come up to us and have us look up to see if a provider is in net or not. The other thing that we'll be doing as we get closer to go live is outreaching to members who are in active treatment, so that we can also ensure there's a good transition of services, so that we can make sure that they know what the benefits are in the event their provider is not in network. So, for example, if today someone is seeing a provider that's in network, on July 1st that provider is not, the member can continue with that provider for up to 90 days or 12 visits, and we will make sure that there's continuity of care throughout, even if after 12 visits or 90 days the member has not reconnected or the provider has not come in network, we're not just going to drop that. We feel very strongly about the coordination and the collaboration of care so that people are not left without needed services. I also just want to say a little bit about how we do manage the services. One of Beacon's primary models is around our co-location with our health plans. We actually have our staff sitting in the health plan, and what that does is in real time help to coordinate services between the medical side of the house and the behavioral health side of the house, which is really integral because I'm sure all of us know, right, that you can't separate them. Someone with diabetes may also have depression, and it's really important that both sides of the benefits and all are talking to each other. So that is a model we will be having going forward. We will also be having our ID information on the cards of the health plan, so the members will not have to be carrying 2 cards. There will be 1 card. Our number will be on there as well as our website. We will also have the address of where providers can mail claims to on that card. That will simplify things. If providers are unsure as to where they should submit the claims, a member can just hand the card to the provider. And I also am just very pleased, too, that Susan Cooper will be joining us. I know that she's been a tremendous asset to folks, and we're thrilled that she's going to be joining us. And again, I think that's going to help to make this seamless for providers, for members, and for all of you. So I don't know if anyone has any questions.
Come on.
Mental health questions for Beacon, not individual.
I need you out there.
Yes. Contact. Yeah, it's in your packet. It's in the guides on our website. As we said, it went live yesterday, so folks can start calling right away. They can access the website now.
Well, if you do have questions, feel free to approach me. I'll be in the back. I'll be here for the end. I have cards, and I'm willing to give them out. Okay.
Yes.
Does that mean you're reissuing new cards for everyone?
All ID cards, yes, it's an all-new contract, so all of the plans. Yep. So the Unicare card, the Tufts card, will all have this information on it, which really makes it a lot easier. We were having trouble before in that there wasn't a separate mental health card, and all of the information needed wasn't on the health plan card, so now it will be, which will make it a lot easier for folks. Okay. Thank you. So the town of Dracut is joining the GIC for health coverage as of 7/1, and we have 13 communities that are joining the GIC retiree dental plan. For those of you that are in state agencies and are familiar with the retiree dental benefits, we are making some enhancements effective 7/1. The maximum amount is increasing to $1,250, which is very nice, and we are now going to be covering dental implants, which is probably one of the most popular requests we've received. The other nice feature is that MetLife is here, and they'll be talking a little bit about the benefits, but the schedule for the most common items is increasing, which means lower out-of-pocket costs for members. And then the frequency of services such as sealants and fluoride treatment is changing to be consistent with the industry standard. So municipalities, if you are one of the 13 communities, you have a special form. The way the municipal retiree dental plan will work is your address is on the page 2 of the form. The retiree or survivor needs to send that form to you. You need to enter it into your pension system and then send us the original form so that we can enter it in and then feed that to MetLife to get the ID cards out. And let's see. We are also holding a long-term disability open enrollment for state employees. We really want employees to take advantage of this. It's an opportunity to enroll without a medical. which, that they only have that opportunity when they're first hired, so it doesn't delay the process. Because we're trying to really encourage people to take advantage of this program, we're going to have an extended enrollment period, so it starts next Wednesday at the same time as our regular annual enrollment, but our regular annual enrollment for all products is ending on May 8th. This will actually continue till June 14th, and what this will allow us to do is, in addition to giving folks a little more time to think about this option, it'll allow Unum to come out to the various state agencies and have mini fairs for your employees so they can learn more about the program.
I have a question on that. I had an employee that enrolled, got the paperwork back for the medical, and then just never did anything with it. Would she be considered declined, or?
No, she wasn't declined. So the question is, she never returned the medical forms. So two key things that I didn't mention that are on this slide is they absolutely have to use the special form. So don't let them fill out a Form 1, because if they fill out a Form 1, it'll go through the regular medical process. They've got to use the special open enrollment form. And the second criteria is they can't have been declined before. So as long as they haven't been previously, no, if they've been previously declined, then they'll be subject to the medical. So those are the two ways that'll kick the medical. If they use Form 1 or if they were previously declined, they will get the medical form. And that doesn't mean that they won't be accepted. They could be accepted, but that will trigger that process. Our WellMass pilot program is going to be able to be continued, and this is for executive offices, constitutional offices, and the legislature, and early retirees. As you know, Ashley is here. She needs WellMass champions in each of the agencies, because you really need a point person to rally the troops and get everybody on that walking challenge. We just did a weight loss challenge. Did we get the results yet? They're still coming in.
Yeah, a lot of pounds lost.
All right. I don't know that we at the GIC lost a whole lot of pounds. We were under tremendous stress this winter. There was a lot of eating. I don't know how we made it till today, anyways. Anyways, the big thing here is not only does she need wellness champions, but she also needs employees that are eligible to fill out the health assessment, because once you fill out that health assessment, that's what triggers your eligibility for coaching to try and give you tips for how to lose weight and get more active and stop smoking and all that great stuff. So if you have folks eligible, I encourage them to take their health assessment. And now I'm going to have MetLife come up. This is Teresa Matrenga.
Hi, everyone. I'm going to give you just a high-level overview of how the dental plan operates. The retiree dental plan is what we call a schedule plan, and what that means is when the retiree joins our network, they'll receive a handbook, and in the handbook, we'll list all the services that are covered under the plan, a description of the services, and what the plan pays for that particular service. And I'll explain mathematically how that works in a minute. A retiree can use any dentist in our network. We have over 218,000 dentists throughout the country. There's a little over 4,800 in the state of Massachusetts. And for those dentists that are in our network, they agree to accept a negotiated fee, a discounted fee for the service. And those discounts range anywhere from 15 to 45%, depending on what part of the community the dentist is located in. And of course, for those dentists that are not in our network, they charge whatever they normally charge for that particular service. So let's say I'm a retiree and I'm going for my cleaning, and I'm going to make up this number. Let's say the plan pays $75 towards that service, and I'm using a dentist that's in our network, and the contracted fee is $80. So the plan's going to pay $75, and my out-of-pocket expense will only be $5. Conversely, if I decide to see a dentist that's not in our network, and that dentist charges $100 for that same service, the plan's going to pay $75, and then I'm responsible for the other $25. And that's how it works for every single service that's listed in the handbook. There's an annual max on the plan of $1,250. There's no deductibles and no coinsurance. It's strictly just a schedule plan. One thing that's important to note is that once a retiree enrolls in the plan, unless they decide to leave the plan and then they want to come back in again, they cannot come back in again. So once they're in the plan, they need to stay in the plan, and that information is outlined in the handbook as well. As Cindy mentioned, there are several changes for 2013. MetLife took a look at some of the highly utilized codes that we see coming in today, and we've isolated 10 of them, and we've increased the plan reimbursement on those 10 codes, which translates into savings for the retiree. So the plan will be paying more money towards that service, and the retiree will not have as much out-of-pocket expense. And then, of course, we're very excited to offer implants effective 7/1 as well. I've been going to health fairs for a while now, and that's a very popular question that comes up from the retirees, so we're very pleased to offer that starting in July. Cindy had also asked us to touch on COBRA, and just a little bit at a high level how that works. So if an active employee retires, that retiree can choose to come into the MetLife dental plan immediately, or that retiree can decide to go on COBRA. And if they go on COBRA, the COBRA plan will mirror the plan that they had as an active. And then once that COBRA runs out, which is typically 18 months, then the retiree is free to join the MetLife dental plan. And MetLife has taken over the dental plan in July of '07, and since then we have more than doubled our membership. So does anyone have any questions? I'll be here too at the end as well if anyone wants to come up and ask a question. Yes?
I'm sorry if I missed it, but did you touch base on, like, say I have a lot of retirees out of Massachusetts in different areas? So the same thing, you have providers in those areas?
Yeah, so the question is for retirees that live out of state. MetLife actually has 218,000 providers across the United States, and so there is coverage everywhere. And obviously you can go to any dentist you choose, it's just you'll have higher out-of-pocket costs. Yes?
This is not just for municipal.
No, it's for any state retiree. So there's 3 options to enroll. You can enroll as a retiree or survivor. You can enroll during annual enrollment. You can enroll at retirement, or you can enroll when your COBRA ends. And that's what people generally do. So because usually the benefits are a little richer with an active plan because it's not a schedule of benefits. It's I get 100% coverage for preventive care or 80% coverage of, I don't know, root canal. I don't even want to think about that. But so usually it's a little bit richer benefits. So folks generally will do the COBRA, and then when COBRA ends, join the retiree dental plan. Nancy again.
I think it said it in information you got, but they don't have to be on the GIC's health plan.
Oh, right. So the question was, do they have to be in GIC health insurance to be eligible for retiree dental? And the answer there is no. But I do want to point out that we are mailing to everybody that has GIC health insurance, because you're a municipality that's joining the retiree dental plan. So the 5,500 folks that are now eligible for retiree dental will get a mailing with the enrollment form. This is for the 13 municipalities joining. And then on the state side, every month, MetLife gets the file of folks that are retiring, and they get a packet as well. And then obviously every annual enrollment, we notify them in their guide that they're eligible for the benefits. So every annual enrollment, they have the opportunity to join. Yes?
You're retired from Housing Authority.
Housing Authority is GIC. Retiree dental, your retirees are considered us. Right. Okay, so the question is, our GIC dental, and that's why we're not even bringing up our GIC dental vision plan. It is for a very small percentage of our population. The GIC dental vision plan, which is also provided by MetLife on the dental side and by Davis Vision on the vision side, is strictly for folks that are covered, that are under the executive offices, managers, and supervisors that don't have access to a union-based plan. So it's a small part of our population is in the GIC dental vision plan. Most agencies offer a program through their union. So we're not even going there. So, but your retirees are GIC. GIC retirees, they get a benefit decision guide in their benefit decision guide, and that's why we invited MetLife to come, because I think a lot of state agencies aren't familiar with this benefit, that they are eligible to join the GIC retiree dental plan. They also have access to the vision discount plan, which is a great program as well.
That's confusing because like maintenance has union, but administrative don't. I don't know how the other housing plans work.
Right. Yeah, but I'm again, most GIC members do not have access to the GIC dental vision plan. We cover 400,000 people and only 10,000 are in the dental vision plan. That's why we're not even discussing our dental vision plan. Yeah. If they didn't.
I think the easy part, if they are retired, they get this benefit.
Yeah.
Period.
Right now, I can have dental.
Yes.
Okay.
This dental plan, you are eligible. But if some people, you gotta remember, a lot of people don't get the regular GIC dental plan.
Yeah.
So we have COBRA, you get it through a union. All of those people at the end of that benefit can sign up for this or take it when they retire. But if they are retired, they get this benefit. If they are a surviving spouse from any authority, any offline, any UMass or HRCMS agency, they get this benefit. The trouble is they have to make a choice. If they want to take COBRA from their union or from whatever plan they're in when they retire, and at the end of that COBRA period, as long as they're still retired collecting a pension, they jump on this retiree dental plan, or they jump right on it when they retire. But everybody gets this as a retiree.
Yeah, our eligibility is a little complicated.
That's why I don't have any hair.
That's why, I think of it, I'm writing 128 pages of these benefit decision guides, but there are 3 versions. And it's like, okay, am I working on active state? Am I working on retired state? Am I working on municipality? Very different. Our website really has a lot of comprehensive information on it, and I want to be sure that all of you know what some of those resources are. Our benefit decision guides are all online. All of the content of the guides is online, and folks that are visually impaired can read through all of the text on the guides on our website. They're also available as downloads. And one of the sections that you hopefully are familiar with are answers to FAQs. This is an invaluable resource for your employees, and I want to make sure that you all are encouraging your employees to visit these sites when they have life events that may affect their benefits, whether they have a dependent 19 to 26, divorce, legal separation, and remarriage, employment changes as far as hours, new hires, that type of thing, family status change, moving out of a planned service area, address changes, layoffs, leave of absence, leaving service, life insurance, LTD, Medicare, and retirement, and turning age 65. The number one question we get at the health fairs is, what do I need to do when I turn age 65? All of those answers are on our website, and please, there's a big phenomena called aging population, and definitely refer your employees to those sections of the website. The other section that is critical for you all is this coordinator information section, and it's right on our homepage. And from here, the employees can locate you. We update this file every quarter, so folks can search by the agency or municipal name and find out who their coordinator is. Coordinator news, that section has information on these sessions, all of the annual enrollment news. 2 of our plans are having breakfast sessions, and that information and RSVP is there. Ordering supplies. Be sure every year that you we won't give feedback on MassGov today. Be sure that every year you get new provider directories for your supplies, because obviously the provider directories change each year. So all of our plan contact information, whether it's health plans or long-term disability life insurance, all of that contact information is right here under the coordinator information section. And then the piece de resistance is our all-new manuals. Donna and Paula and I have been meeting every single week since last summer to put together all-new comprehensive coordinator manual, step-by-step procedures for you to enable you to do your jobs. So there's 3 different versions. There's the municipal one, the offline agency one, which are for housing and redevelopment authorities, and the HRCMS and UMass ones. We've broken it out by section, and you'll see that the description is pretty comprehensive as far as what is under each of these sections, what procedures are under each of these sections, and I won't read through all of them, but, you know, leave of absence, if people have divorce or remarriage, what do you need to do? What steps do you need to do to administer your job? And so all of that information has been updated on our website. We are sprinting towards the finish line, and we'll have downloadable versions for you in the next couple of weeks. So you, if you would like, will be able to download and print it and have a nice pretty manual. You can 3-hole punch it and put it into your into a binder if you'd like to do that instead of on our website. So as I said, the website version, the whole website has been updated. All of the procedures are up to date, and we definitely encourage you to use that resource. Okay, we're going to move on. Okay, so I've talked about our website. Again, the SBC, easy to understand websites there, the coordinator supplies, forms, all the forms are on our website, and for state agencies, you also got the new beneficiary forms. Those are the only forms that aren't on our website, and that's so if Aunt Matilda is close to death, somebody doesn't fill out a beneficiary form and say they want to be her beneficiary. We've talked about the coordinator manuals, and this is where we all would like to be, is Florida, on the beach. Lucky Judy just got back from there. We could have all used a little palm tree this winter, but we didn't get one. Anyways, when you have retiring employees, make sure that they look at our website, because that whole FAQ section I walked you through has the most common questions they're going to have about retirement and their GIC benefits, about Medicare, and about turning age 65. Those 3 sections are invaluable. So every page of our website has a link to that FAQ. Please, 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 you know, 10,000 baby boomers every day are turning age 65. This is the #1 question we're getting. You guys are probably having a ton of people retiring. Please refer them to that section of the website, and they can download the retiree a decision guide, or they can call us for a copy. They can view it online. The retiree guide for state retirees and survivors is there. Municipalities, it's one guide. You can give them another guide. And so new this year is we, because we get this request, we've always let people, the retirees and survivors can always write to us to change their plan during annual enrollment. But some people like to fill out a form. So we're giving them the option of a form. So if they're a Medicare retiree survivor from either the state or municipalities, we've got this new form on our website, and they can fill this out as long as both the retiree and the covered spouse, if applicable, are on Medicare. If they're both on non-Medicare, they can use the regular Form 1 or Form 1 MUN. So I sent you an email. All of our forms have changed for annual enrollment except for the 319 form and the handicap dependent form. So please be sure to discard your old versions. And I'm just going to quickly highlight some of the changes. This is the state Form 1. We have really made, now for the first time, this was already on the Form 1 MUN, when you have a retiring person, if they are Medicare eligible, you'll now can fill in the Medicare plan they want to enroll in. So this is new for state agencies. We've also made the leave section a lot clearer, so you can see, you put right in the leave start date, leave end date, last day on payroll, return from leave date. So very easy to understand, and hopefully will be helpful for correct completion of these forms. This is the Form 1 MUN. Again, some clarifying things here. One is date of hire. Oftentimes you'll have a new hire at a municipality, and that is not filled in. This is required. We don't have an interface with you. We need that date of hire there. So it says that it's required. Down here, if you have a school department employee who's leaving and it's January, you just fill out the regular section. But if they're leaving at the end of the school year, then you're going to fill out this section. So those sections have been clarified. This is the IDF form used by both state agencies and municipalities. Here, what we've done is clarified that you only need to fill out the spouse section or the former spouse section if you are covering such an individual. And then this is the acknowledgement form. There's the municipal version and the state version. Again, this is changed because of federal health reform. You've now got to give the employee a copy of this form so they have in their hand where those SBCs are located. Don't send these forms to us. We don't want more paper. We have plenty of paper. But you need to keep a copy and then give the employee a copy of this form. The HERD form, the jurisdiction for HERD forms moved to the Connector Authority as part of Chapter 224, what I talked about at the beginning, the whole healthcare cost control. Some new agencies were put in place. Division of Healthcare Finance and Policy no longer has jurisdiction on the HERD form. It's now through the Connector. So if you are an HRCMS or UMass agency, the form is the same. But if you are an offline agency or municipality and you're on our website, you'll go to the Connector's website for the form. Again, you want to make sure that anybody that is GIC eligible who does not elect to enroll in health insurance during annual enrollment, they don't have health insurance or they don't enroll in health insurance, they need to fill out a HERD form. This is a protecting you form to show, because in Massachusetts it's required that you have health insurance. They need to fill out a HERD form every year, and then also your folks who are not GIC eligible have to fill out a HERD form, so you let them know about the Section 125 plan. Divorce and remarriage, one of our favorite subjects. This continues to be a challenge. We absolutely need to know about divorce and remarriage as soon as you know. So please, a couple of things. As soon as you hear of a divorce and remarriage, there's the whole procedure on our website. Please follow that. But I'm going to have Paul talk a little bit about what happens if there's a delay in notification and how this will hurt the employee. So again, it's in the employee's interest to report this, not when they're getting remarried to the 20-year-old secretary.
There's some benefits to that. All right, one of my favorite subjects at group insurance is divorce and remarriage. Where can I start? There is a law for state employees, authorities, and municipalities that now come under GIC under Chapter 32A. That law went into effect March 27th, 1985, and it states that you can continue to cover an ex-spouse under your family plan at no additional cost until such time either party remarries. Upon remarriage, that ex-spouse is off that family plan regardless of the language in the decree. So that ex-spouse has to come off. What happens is that we put it in our guide, we put it in the newsletter, we put it in all our annual enrollment. We never learn about an employee who gets a divorce. So if you have any communication, any newsletter, anything that you can send to the employee, remind them, if they get divorced, they need to come see you, they need to notify the GIC, because what happens is, we usually find out about the remarriage, that the spouse has been on there and we never knew about the divorce. But what happens, to put that new spouse on, GIC will go retroactive to the date of remarriage and remove that ex-spouse, regardless of the number of years. We had a case last month. We went back to 1985. I have a case now, $86,000 in claims because the person got remarried 6 years ago. We just found out about it. The ex-spouse or the insured is going to pay the $86,000, not GIC. So it is important that they learn about this remarriage or a divorce. Let us know, because we can go back to the date of remarriage. There's no cap on that. We tell the health plan to rescind the claim and start retracting any benefits that were paid. So what happens, ouch. So if you hear about it, you have any communication, let your employees know, well, they'll say, my decree says I'm supposed to cover my spouse, ex-spouse. That's true. But the remarriage will allow you to continue your ex-spouse, but there's now an additional premium, either through COBRA or a divorce spouse rider for that ex-spouse, but at 100% premium. So it's important that they got to let us know, because I can't tell you how many people, that's all we do. We go retroactive. I mean, we get, I would say, 120 divorce cases a month and about 30 remarriages a month out of 400,000 people. So we're always going back, and the health plans love it. I mean, they just love when they hear that they have to go back. But if somebody got divorced before that March 27th, 1985 date, the ex-spouse is not even eligible to be on the insurance at all. Prior to that date, there was no provision to keep that ex-spouse on. So it's one of the thorns in our side at GIC. So, and some days we get divorced, so.
Oh, we're constantly.
I just have a quick question. I have an employee that is divorced.
Yeah.
But the ex moved out of state.
Uh-huh.
Moved to Texas.
Yeah.
And he's still paying for a family plan.
That is true.
Which, of course, doesn't cover them out in Texas.
The ex-spouse is allowed to stay on the plan. If the ex-spouse is out of state, most likely they have to go into the
Unicare
plan,
Basic.
because
The whole
that is
family
the
needs to
plan
be in
that's
Unicare
gonna
Basic.
cover the person outside of Massachusetts. Now, they have to know if they get remarried, someone has to tell us. They'll either tell you they don't know, or they don't know if they get married, I have no contact. It doesn't.
So he still has to cover her?
If, the way it works is, we get the copy of the divorce decree, 3 sections, signature page, absolute date, and the section on health insurance. A lot of people tell you there's no health insurance language. If there are children in that marriage, there's a health insurance language, I guarantee you. If it is silent on health insurance, the ex-spouse stays on that policy. Even if the language in the decree is silent and there's no mention of health insurance, the ex-spouse stays on. Ex-spouse cannot come off that policy until the insured goes back and gets a judgment with the court to remove that ex-spouse. So there's a lot of different.
We're getting close to time, so I just want to cover one more law that's gone into effect. You had a quick question?
If there's language in the divorce that says the ex-spouse has to be covered, but then the ex-spouse decides that he doesn't want to be covered, can he request?
Yes. Ex-spouse can just send a letter saying, I don't want the insurance. As long as the ex-spouse has signed it and made that declaration that they don't want to be covered, we'll take the ex-spouse off. That's fine, but they have to do that. Not the insured telling us, well, they don't need the insurance, so I want to take them off. No.
Yeah, they're always the most pleasant members to work with. They're always just so happy.
Yeah, please, you have to write a letter directly to me, even on the divorce and remarriage.
The other thing that happened recently was a law passed that would revoke the beneficiary. So if the insured names his or her spouse as his or her beneficiary, and then they get divorced, that designation is revoked. So keep in mind that he or she could still name that person, but they need to fill out a new beneficiary form after the divorce to name whoever. So every time you have a divorce or remarriage, make sure to give them a beneficiary form if you're a state agency. The other thing is, obviously, we send out those benefit statements every January that lists who the beneficiary is, and they really need to make sure that they're keeping that beneficiary up to date.
What happens if they don't?
It's revoked. So in other words, it would then go to the estate or whoever else is next. Make sure to keep your agency and employee addresses up to date. Please, please, especially if you have multiple locations. This is a bane of our existence, especially during annual enrollment when we're spending a lot of money to ship benefit decision guides. Please send email addresses and coordinator changes to Winnie Yee. Her contact information is here. We really appreciate you keeping that up to date.
Salary, it's tax-free because employees pay for the benefit, so no taxes come out when they file a claim. They have a 90-day elimination period, meaning they have to be out for 90 calendar days. We encourage employees to file early. The process is telephonic. All the details on the process are on the GIC website. And my contact information's out there, so I encourage you to call me if you have any questions, if you have a claim, and you just want to walk through the process. I can help you with any questions that you may have. We know that a lot of employees have a lot of sick time, and a lot of times employees wait to file. And again, if you could just counsel employees to file
set that up with you. Connector open enrollment for non-GIC eligible employees. This is the information. It's on our website. It's again May 1 to May 31. I mentioned earlier, we don't know what the ramifications yet are as far as federal health reform. We will be in touch with you about that. Great enhancement that's going to be rolled out starting this summer and into the fall, and that is the ability of employees to view their GIC benefits online. They'll actually be able to see their beneficiary information. And it's like getting a benefit statement online. So we'll start mailing pins and all of that stuff. It'll be a scheduled rollout, and we'll be in touch with you as more information. This will be for both state and municipal employees. And so it'll be a home mailing of passwords, and in the future they'll be able to make changes during annual enrollment. So very exciting, a lot of work, really excellent. And then, as you know, we rolled out new revised bills recently on the state and municipal side. This is all your COBRA folks and your divorced spouse riders. And then on the state side, it's the leave of absence and missed payments. Make sure if you are a state agency and you have somebody going on leave to remind them that health insurance isn't free. They're going to get a bill. They need to pay it. It makes it easier to pay it online. They need to make sure they're not just sending $20. It costs a little more than that. So this tells them, if they only make a partial payment, what's going to be canceled. So again, they got to pay their bills. We have some new resources. The QR code is on your health fair poster. Folks can use their phone and scan it and find out more information about annual enrollment. We're now on Twitter. I'm tweeting every day. And this coordinator session is going to be on YouTube, so we'll get that out to you too. Make sure your employees do their homework during annual enrollment. They find out what's changed. They find out that make sure their doctors and hospitals are in the network. They make sure their kids' doctors and hospitals are in the network, and their spouses' hospitals and doctors are in the network. That continues. Some people have central focus. So do you all use this in the guide? Okay. Do you use it mostly in-state, or do you use it out-of-state too, or both? I mean, do you like this page? Okay, great. So far, we're... Dolores is getting overruled. And now this is on YouTube, so I have the proof. The guide shipments, they're happening now. They're on our websites. The retiree and survivor shipments are going on. Copay tiers, make sure your employees check that. Those change every July 1st too, as there's new data. Don't forget limited network plans, same benefits, just fewer providers, a lot lower costs. We've got 14 fairs this year. There's 2 that are going to have sign language interpretation services. That information's on our website. The mini fairs for LTD will be on our website. And that's everything. Thank you all for coming.